Hello, everyone, and welcome to the Hub Innovation Series. Today's session will focus on iKure, a digital solution for climate-resilient last-mile health coverage. My name is Ebele Anidi, and I'm the Director of Partnerships and Engagement for the G20 Global Innovation Hub for Improving Value in Health. The Hub Innovation Series aims to foster and support innovation across the G20 member states by spotlighting innovative, practical, and impactful solutions for the inspirational health pioneers who are working to ensure a new era of high-value health systems. Today, through our partnership with PATH, I'm excited to introduce one of the winners of the PATH Climate and Health Challenge. With an increasingly complex range of challenges from health systems due to climate-related health emergencies, iKure is a climate-resilient, digitally enabled healthcare platform that leverages a network of hub-and-spoke clinics as well as highly trained community health workers to address the primary healthcare needs of communities at the last mile of traditional health service delivery. Sujay Santra, founder and CEO, is joining us today to share the iKure story. Welcome, Sujay.
Thank you, Global Innovation Hub, Path, Ebele, Terena, and team for inviting me and to share our story of iKure.
You're very welcome. I'm so glad that you're with us today. And let's kick off the conversation. This climate resilient, digitally enabled healthcare platform is really timely and a really unique health innovation. Sujay, can you share the origins of iKure and maybe walk us through the essential elements that make this a primary health tech platform that's really connecting the last mile?
Sure. So to begin with a quick introduction about my roots. So I was born in a village in West Bengal, which falls in the eastern part of India. And since my early childhood, I have seen that for anything to do with healthcare, patients have to travel all the way down south to Chennai or to Mumbai. And in many cases, when they were traveling to such hospitals, many of the cases were reported at a very late stage. And that had, they had to do different kind of interventions, procedures, surgeries that pushed the entire family back to poverty because most of such treatments was out of pocket. And then from my childhood, I went back to do my master's in computers. I joined as a junior scientist at NRSA, National Remote Science Agency, Space Agency in Hyderabad. And I was doing pretty well in my career. From there, I moved to IBM and then Oracle. I got 5 awards in IBM and 6 in Oracle. But something within me was a void. I was trying to think that whatever work that I'm doing for me, how is it helping to my community? Because my community was still falling behind when it came to healthcare. And then I got an opportunity to do a startup of my own. I figured it out that during this time in 2010, most of those technology has been built around businesses. When it came to telecom, space technologies, finance, and many others, it was pretty well in terms of the technology adoption. But when it came to healthcare, most of the technologies was built around the businesses, meaning that when a patient was walking to a hospital, all the patient and registration was happening. And the moment the patient was walking out of the hospital, the patient was losing any contact with the doctors. And in case they had to reach out to the doctors or the surgeons, it was an extremely difficult and impossible affair. That is how the whole concept of iCure started, wherein our thought and our purpose was how we would be able to build and design solutions, and especially the technology solutions that is driven around the patients, which matters the most when it comes to healthcare. Next slide, please. So over the last several years of our journey, iCure, it started as a pure technology company. Towards 2014-15, we understood that just technology is not good enough to create the right kind of impact. Even though we were a little ahead of time when it came to technology innovation, we had to depend on government. Government had its own priorities in place, and as well as NGOs where the technology was not an important priority. So we are trying to figure it out that how we would be able to stitch everything together. We started making our hands dirty and experimenting on the whole healthcare delivery model. We have seen many examples that for a simple healthcare, the patients have to walk anywhere between 20 to 20 kilometers on an average. I would like to share an incident. This was in Salboni, which is a very remote area in West Bengal. And this is back around 2012-13, wherein a steel plant was coming up. This was a time around 1 p.m. And I saw few women hurriedly trying to come across on a hot sunny day. And I saw that when they reached to the clinic, the doctor had already left. And we
Mm,
were figuring it out that these patients, they had two options. Either they had to walk in for additional 10 kilometers, mind you that they had already walked for 12 kilometers on this hot sun, or they had to wait for another 2 weeks to see the doctor.
mm,
That shook me within that if this is the situation of the simple basic healthcare needs, what is happening with thousands and millions of the such people all over the country? And there we try to figure it out that how we would be able to deliver simple solutions. And what is the simple solution is a one window approach. Normally, even if the patient is lucky, they would be able to see a doctor in a government facility or in a private facility. But in most of the cases, the medicines are not available. So they have to walk for additional 5 or 10 kilometers. And that is where iKure started to create a one window approach, meaning that when a patient is walking to a facility, they would be able to get access to doctor consultation, medicine, different diagnostic setups. That is how we thought of creating a holistic healthcare delivery model. See, in the last several years of our journey, we have touched more than 20 plus million people. We have treated more than 3 million plus underserved patients in the community. Next slide, please. Of course, we all know about the multiple healthcare challenges, and the pandemic has been one of the biggest examples for that. Nobody would want to hear the different horror stories that we have all gone through. What have been the major challenges? The major challenges, many. The huge healthcare infrastructure disparity in place. For example, the number of neurologists in the city of Chennai, which is one of the metros in the southern part of India, is more than the number of neurologists than the entire northeastern state, which comprises of 7 states in India. You could imagine the healthcare disparity. If you open up any of the reports, be it by KPMG, PwC, or any others, how they describe the healthcare infrastructure is number of population to number of bed ratio. But we have seen the pandemic wherein less than 4% of the 5% patients were actually landing to the hospitals. Remaining 96% of the patients were getting treated outside of the hospital settings. So the major indicators is unless and until we are able to strengthen the public healthcare infrastructure, we would be nowhere. That is the biggest problems and the myths that everywhere we feel that if we want to solve the healthcare problems, we need to build hospitals. No, time has come that if you want to really think of the people, we have to strengthen the public healthcare. Then there are other problems related to different gaps that we have seen during the COVID-19, not only the treatment, outside of the COVID-19 patients, we have seen huge amount of challenges for other chronic ailment patients. Patients who are diabetic, they were not able to get their insulin injections on time. Patients who
mm,
are pregnant mothers, we don't call them as patients because pregnant mothers were received either missing their important vaccinations that were very, very crucial for themselves and their babies. And as well, especially for the rural population, there were huge disparities in place. So all that astounds to that, how do we really solve that problem? To me, one of the fundamental problems has been that if I'm traveling to any part of the world, let's say if I'm going to New York, I have my own debit card. I will be able to draw money from my Indian bank easily within seconds. But if I need access to doctors, if I need access to care, if I walking into any doctors in any part of the world, if they ask me, do you have a health record? I say, I don't have because my healthcare is not connected. The moment I'm walking to any clinic, to hospitals, to other diagnosis centers, these are simply not connected. And
mm.
that is the whole fundamental things there, the how you're able to stitch and everything together. Next slide, please. How iKure can become a collaborative platform. And in this collaborative platform, we have tried to address some of the fundamental problems. One of the fundamental problems is it really possible to track and monitor the entire journey of a patient? Remind you that during the pandemic, one of the major problems was of contact tracing. One fine morning when you open up the news, we saw there is a new strain which has come up in South Africa, and within just few days it has landed in India. And we are not able to do anything about that because simply we don't have any technologies to track and monitor the journey of the patient who are carrying such virus. That is where we have to understand that unless and until we are able to solve the fundamental problems of the healthcare, in this case, the patient's journey, right from the patient's door to the clinic to the hospitals and going back, we'll never be able to solve any problems like pandemic or such kind of epidemics in place. So at iCure, we have been able to understand and pinpoint and manage and track the entire journey of a patient through our digitally enabled model and through our community health workers. Not only that, we all speak about artificial intelligence. We have seen many of the people are speaking about artificial intelligence, but you try to even dig deeper, you would see that most of these people are dependent on two sets of data. One set of data is the private hospitals, and the other set of data is the government facility. Private set of hospitals accounts for less than 8% of the healthcare data. Why? Because obviously for tertiary care, it amounts to only less than 10% of the entire healthcare. That's why you would be able to see 90% of the healthcare data is lying out of the hospital for which we don't have any intelligence in place. And the other is the government data, which is in many cases are dated. So obviously, if you want to bring in any intelligence, if you want to bring in any data science, your artificial intelligence will not work. I have been also nominated as part of the National Core Committee of CII and for artificial intelligence, and I interact with the bureaucrats or principal secretaries of several state governments and central government on a monthly basis. And one of the fundamentals that we have done is one of the major problems that we all see is the lack of data on a unit level metrics. Whenever I travel to any part of the world, let's say if I'm going to New York and I need to take out money from my Indian bank, it's just so easy. It is out in just a couple of minutes. Whereas in case of access to healthcare, if I want to walk into a doctor or even a healthcare facility, if I want to pull out the data on healthcare, I don't have because they are not integrated in manner. And that is where the core problems are that we are trying to build on intelligence. We are trying to build on AI. We are trying to build on intelligence on data science. But the core fundamentals of how do we track, monitor the patient's data when it comes to their home, their clinic, or even the hospitals, they are not seamless and they are not integrated. And that is where iCure is trying to solve those fundamentals. How? One is the flow of the patient through our community health worker model. Their patients being they are being treated at their homes or at the clinics or at the hospitals, we are trying to stitch and integrate all together as part of the continuum of care model. Not only that, the other important fact is we have integrated multiple medical devices as part of a platform. So let's say when our health worker is measuring vitals, it could be blood pressure, SpO2, ECG, temperature, and many other parameters, the data is captured seamlessly with minimal or zero human intervention. What that means is that this can eradicate a lot of data or errors which arises out of human errors. And that is how we have been able to understand that if you want to build on AI solutions of intelligence through AI and other purposes, unless and until you are able to solve the core fundamental problems of integrating the data and ensuring data loss, data errors due to human errors, you will never be able to create intelligence. And that IQ, we have been spearheading such efforts. Not only that, our supply chain also, for example, during the pandemic, we have seen that we have been flooded with oxygen concentrators, pulse oximeters, and many other devices and equipments, and they landed all at a district facility. But from that district facility to be delivered all the way up to the last mile, up to the village, nobody knows. The other supplies, medicines, nobody knows. And that is where at iCure, we have been able to really focus on the supply chain problems. So when our health worker is going and seeing a patient, they are able to capture the vitals. The vitals are being shared with the doctors. The doctor is speaking with the patient, issuing the prescription. The health worker gives the medicines as well as supplies such as sanitary pads, spectacles, and we have created an integrated supply chain network. So we can see that how the whole distribution of the supply chain is happening. And this kind of solution can really help us to prevent another pandemic from happening with effective and optimized supply chain management. And that is how we have been able to create multiple intelligence with regards to epidemiological study, with regards to the patient's behavior, with regards to the supply chain challenges and things like that, and also the integrable data integration capability.
I mean, Sujay, you're talking about this truly holistic approach and model and tool that has relevance in a number of different fashions. I mean, obviously, you just spoke about the context within the context of the pandemic, but even as we think about the fact that you won and your team won, the iKure team won a recent climate and health challenge that Path put forward, because this also speaks to a tool and a resource and a platform that would be really helpful as health systems across the world are starting to try to, future-proof and prepare for the increasing complexities of climate-related health risks and health challenges. You started to walk us through the workflow of how the iKure platform both begins and ends with patients and beneficiaries, but would love if you could maybe walk the audience through like the actual step-by-step workflow diagram, and then what, if anything, has changed in your approach. I know that you're an innovator, you're looking to constantly improve and adapt the tech platform to deliver for the very people who need it. And so has there been any changes? I know when we discussed and were in communication, you referenced the establishment of a new living architecture. And so wanted to maybe provide some time for you to touch on that. But let's start first and foremost with the workflow diagram.
Sure. So in this case, our fundamental, as I said, focus and things where we are trying to empower the frontline community health workers. So these community health workers are none other than the members selected from the community. In most cases, they are village women who are selected and trained that how they can capture vitals, how they can communicate and mobilize the community, especially the patients and others, on different healthcare behaviors, healthcare practices, as well as to treat and help them through doctor consultation whenever they need, and help them with delivering of spectacles, sanitary pads, medicines, and others. One of the major challenges are, if I take a terrain like Sundarbans. Sundarbans is the world's largest mango grove, and from the Indian side, it is home to 104 islands, out of which 54 islands are inhabited, meaning that the people stays over there. There are some of the islands like Kumilmari, wherein we are operating. From the main port to go to that Kumilmari island, it takes almost 7 to 8 hours by boat, and all that too when there are clear skies. In case of monsoons, they have to wait till the skies are clear. That island has 22,000 population. And do you know how many number of doctors are there in that island? Zero. That is where iKure has been able to deploy frontline community health worker and set up clinics. Now, again, imagine this community health worker is engaging with the patient. The patient has problems related to pain, cough, cold, fever, maternal health, menstrual health, or any other ailments. The health worker is able to address those things and capturing the data. But in many cases, the health worker may not be able to reach out to the doctors then and there. So our objective was that how is it possible to bring in intelligence to help these health workers? Let's say based on the parameters that have been captured for a pregnant mother, how do we assess that whether the pregnant mother indicators are normal, moderate, or severe? And in case of they are severe, how we can quickly expedite and bring in the intervention of a gynecologist and the doctors for the next set of actions. So through this intelligence and the risk stratification model, our objective has been that based on the data that is being captured by the health workers, how we can create local intelligence so that these health workers is able to address those situations and help these patients then and there live in such remote settings. And through different interventions, modeling, and the data visualization, it is helping us to optimize the resources. Again, as I mentioned that for a country like in India and also many of the developing nations, the major problems are the healthcare disparity with regards to the number of healthcare givers and healthcare seekers. And the only way that we would be able to solve that is how we would be able to optimize the resources through technology, innovation, and integration of the model. That is at iKure we have been trying to do.
So just maybe to build on that or take a next step here, I know that at iKure, the diagram and that workflow that you touched on is really at the central core of how people and beneficiaries at the last mile are leveraging this platform just to engage with community health workers, but also to stay informed and manage their care, even if they are, as you mentioned, 5, 10, 15 kilometers away from the most proximate primary healthcare provider. But would be curious to know, again, as a platform that is was born out of a drive to innovate and to solve a solution. How are you continuing to innovate? And as we see here on the slide, I know that you and your team have been working on and have established this living lab architecture. So would love to hear more about how this facility, how this architecture is intended to connect and build on the impact that iKure has had to date.
Yeah, thank you for that. At iKure, our objective has been that if there is any innovation which is happening in any part of the world, how we would be able to bring such innovations to the community at the fastest possible time. And that is how we would be able to prevent and eradicate or any incoming threats that is coming to the mankind. So in this case, as iKure has been working with many of the researchers from many parts of the world, such as with McGill University, Canada, with MIT, with Stanford, and as well as with IIT Kharagpur, with IIT Mumbai, and several others. Our objective is that we all have seen research facilities within the heart of a city. Our concept was, is it really possible to bring or create a research facility within the heart of the community? And in this case, we have set up, or we are going to set up this research facility, which we call as the Living Lab, just on the banks of Sundarbans. Already, iKure has been working in the Sundarbans for the last 2 years, and now we are able to see patients on the primary care level. This living lab would serve multiple purposes. One, for all the patients who are coming from the different and remote islands, they would be able to get the daycare treatment at this lab. And in case they need tertiary care support, we would be able to refer them to different hospitals, as well as these researchers would be housed over there, and they would be able to access, interact with the communities, discuss multiple problems related to clinical parameters such as gynecology issues, maternal issues, mental issues, and many others, as well as they would be able to go to the communities to focus on many other challenges related to climate changes. For example, Sundarbans, as I said, is a very, very climate sensitive area. It has seen 4 cyclones in the last 2 years, and every such cyclone has caused huge amount of devastation. So we are trying to understand the different parameters, that when it comes to the impact of climate change on health, what are the different metrics that we need to measure? What are the different metrics that we can monitor over a period of time, so that we are able to create a good amount of knowledge repository, which could be a problem for the researchers to ponder on, and how you would be able to create scalable and sustainable solutions, so that these solutions can also be replicated in such climate sensitive areas across the globe. And that is where this living lab, we invite all of you to come and partner for this facility. So this facility is the part of the ecosystem wherein the researchers would be able to engage with the patients, understand the different climate sensitive challenges, as well as the other challenges on the ground, and create long lasting sustainable solutions for the country as well as for the globe.
Perfect. I mean, I think you're already speaking to and touching on the relevance of something like a living lab architecture, not just for the context of India, but countries around the world, right? You're talking about where and how can we scale up sustainable, climate intentional, climate resilient solutions. And so even in the architectural build itself, you're accounting for solar and wind and melding it within the context of traditional architecture to establish a new age of healthcare facility, healthcare center for people. And at the Global Innovation Hub, we have a membership that includes representation from across the G20, partners that include both, WHO, OECD, PATH. So we have a truly global membership and a global audience. And so, for the invested stakeholders who are tuning in from across the G20 plus nations, what are your future aspirations for iKure? Where do you see and how would you describe the path forward from here?
Yeah. So for us, there are, again, we are trying to just scratch the surface when it comes to the huge amount of problems that we all see when it comes to the public healthcare. Couple of things which we are all doing is, one is, we have partnered with Community Science Alliance, and our objective is that how we would be able to create conversational module. For example, let's say when a patient is interacting with a health worker, and the questions could be related to pain, cough, cold, fever, menstrual health, mental health, and several others, how we can empower and enable these health workers to address the questions related to them. Because as I said, that in many cases, these health workers may not be able to reach out to the doctors real time. And so through these large language modules, we are creating clinical pathways. So let's say based on the questions, we are creating these branching modules. Based on that, these health workers would be able to identify the problems and help the patients address different things. How this is going to help? To help improve the trust factor of the patient on a health worker, because then the patient would understand that okay, if this woman is knocking at my door with the medic bag, with the different equipment, as well as with LLM AI module, I can ask questions and I would be able to get satisfactory answer for that. And that is how it is going to be a game changer, because it is going to be on vernacular languages, and we are creating around 50 clinical pathways. So this Community Science Alliance has been backed by researchers from Harvard, Yale, Albert Einstein College of Medicine, and DU, which means that we would be able to engage some of the top-notch researchers to solve some of the most pressing problems on the ground. And that is how we are thinking that through this mechanism, we would be able to empower the health worker through innovative medical devices and technologies such as LLM AI to improve the conversation and the trust factor and relationship between the patient and the health worker. Apart from that, our objective is that we are creating a sustainable community health worker to a community health entrepreneur model. Our objective is that in the 2 years of time, they would be paid a fixed salary on a reducing basis. And at the end of 2 years, they would be sustainable because they would be able to earn incentives for every transaction, be it for doctor consultation, medicine, vitals, and others. And on an average, these health workers would be able to earn anywhere between $150 to $200, which would be a good amount for them to sustain themselves and their family members. And our objective and aim is to deploy 1,000 such ECHAs, which is iCure community health activists, in the next 12 months, and 10,000 of them in the next 4 years. So we have created a strong and solid business plan for that. On an average, these community health workers would be able to see anywhere between 8 to 10 patients per day, and they would be able to solve three fundamentals. One is on the community mobilization, the second is on the clinical aspects, and the third is on the supply chain. And the other important thing which we are all doing is how iQure's knowledge and experience can be well integrated with the government mechanisms. That is where we are working on a lot of partnership with multilateral agencies like ACT, Mark for Mothers, and also with JICA. With objective is that whatever knowledge and intelligence that iCure has been able to create, how we are able to integrate and strengthen the public healthcare. So, for example, we are in discussions with many such multilateral agencies that how iCure's model of community health workers, device integrations, large language models, and others can not only help scale the iCure B2C model, which is the business to consumer model, but also the B2B, wherein we are working with state governments, central governments, and also the multilateral agencies to strengthen the public healthcare. Apart from that, our objective also